Alrighty, hello everyone. Thank you so much for being here and for joining us today for our second learning session on eating disorder awareness. So my name is Kat. I'm with the University of Montana Center for Children, Families, and Workforce Development. Um, our center and the University of Montana's Public Health Training Institute have joined forces today to bring today's sessions to you. So we're just going to dive right in and get started. So first off, we have Dr. Sarah Horvath with Children's Hospital Colorado here to speak with us about evidence-based treatments for eating disorders in children and adolescents. So learning about some of the best practices for caregivers and non-specialty providers. And then after about 30 minutes of that, we'll be followed by the University of Montana's Dr. Caitlin Martin-Wagar, who will talk to us about weight-inclusive healthcare and the role of weight stigma in eating disorders. So thank you both so much for being here. After those two approximately 30-minute presentations, we're going to have a joint Q&A. So please be thinking about any questions that you might have as we get started, and we'll open the floor up for questions a little bit later. Thank you so much again for being here. And with that, I am going to get things started and hand things off to Dr. Horvath.
Hello, everyone. I'm really excited to be here. So as mentioned, my name is Dr. Sarah Horvath. I'm an outpatient psychologist, a licensed clinical psychologist at Children's Hospital Colorado, and assistant professor at the University of Colorado School of Medicine. I'm the director for our recently formed outpatient eating disorders specialty clinic, which is very exciting. And so I split my time between the director role, seeing patients in our outpatient clinic, and then also seeing patients with eating disorders in our eating disorders program, which is a partial hospitalization program for eating disorders. By the end of this presentation, I wish we had a count of how many times I say eating disorders, but we can start that now. So really excited to be talking to you all about evidence-based treatments for eating disorders in children and adolescents, best practices for caregivers and non-specialty providers. So really my goal is, especially the kind of second third of or the last third, I should say, of the presentation, is to end with really solid recommendations and resources that folks could take away regardless of what your role and what your exposure to eating disorders may be. And then because from my understanding, there's a presentation a couple of weeks ago more on signs, diagnostic criteria, symptoms, and prevalence of eating disorders. We're going to breeze through a little bit more of that basic information so we can spend more time on the treatment and best practice recommendations. But we'll spend just a few minutes orienting ourselves to the prevalence and symptoms just so we can situate ourselves within the context of the disorders we'll be talking about today. So with that, while we know that subclinical disordered eating is a lot more frequent, the estimated lifetime prevalence of clinically significant eating disorders in adolescents is around 13%, with a fairly large proportion of those presenting as more of that other specified feeding or eating disorder picture. So specifically, we generally see around 1 to 1.5% meeting criteria for anorexia nervosa, around 1 to 2.5% for bulimia nervosa, 2.5 to 3% for binge eating disorder, and then again with a large portion meeting for more of that subthreshold or atypical eating disorder diagnoses. And then additionally, around 20% of children and adolescents report engaging in some form of disordered eating, which, as we know, could potentially develop into a clinically significant eating disorder. So why should we care about providing evidence-based treatments for eating disorders? Providing the best possible treatment is really, really important because eating disorders are serious mental illnesses and are associated with severe physical and social impairment, distress, and a high risk of mortality. Specifically, anorexia itself has a greater risk of mortality compared to other psychiatric disorders. In fact, I think, oh yeah, I have it on the slide there. The risk of death is fivefold higher for those with anorexia compared to the general population, with some studies estimating an even greater risk. And this risk is likely due to possible medical complications such as cardiac arrest or other organ failure, as well as suicide. So while risk is lower for other eating disorder diagnoses, the mortality rate is still higher than the general population. So because of this impairment, we want to be mindful to only use evidence-based treatments to address these really serious conditions. And then because eating disorders are really, really serious and associated with such a great degree of impairment, we want to try to identify and treat the illness as early as possible to minimize both current and long-term impact. There's some evidence that receiving treatment within the first 3 years or so of illness onset has a greater likelihood of recovery, although it's important to note that recovery is possible for everyone at every stage. Early treatment and shorter illness duration may also help reduce the likelihood of those long-term physical complications that we see that often go along with eating disorders, such as bone density loss, future infertility, muscle deterioration, and risk of mortality. This is also why it's so important that caregivers, therapists, physicians, nurses, school staff, and others watch and screen for potential eating disorders and aren't shy to ask those questions. And then again, although we're not going to focus specifically on the signs and diagnostic symptoms, I wanted to again just quickly provide some context of those behaviors that you might be looking for or potential warning signs. So I won't read through all of these, but these might be signs that you'd see as a caregiver, a provider, a teacher, etc. So things like changes in weight, restricting types of food or volume of food consumed, reporting dizziness or fainting, withdrawing socially, especially not wanting to be involved in social gatherings that involve food, family history of eating disorders. We know there's can be a genetic component, kind of food rituals or rules around eating. So only wanting to use certain utensils, eating in a particular order, etc. Evidence of purgings, like going to the bathroom after meals, or even drinking excessive amounts of water or restricting water. So those can all be signs. So now we know that providing quality evidence-based treatment is really, really important for these life-threatening illnesses. So I'm going to spend some more time reviewing evidence-based treatment for children and adolescents with eating disorders. And I'm going to try really hard to stick to my half an hour because I do get really jazzed talking about eating disorders. So I will try to go through this information as quick as possible. So primary evidence-based treatments for eating disorders include family-based treatment, enhanced cognitive behavioral therapy, and cognitive behavioral therapy for avoidant restrictive food intake disorder. Other treatments with support include dialectical behavioral therapy and interpersonal psychotherapy. There are also very few medications, unfortunately, that are approved to treat eating disorders. Most commonly, we see SSRIs, such as Prozac, for example, to help address the eating disorder, or more likely, more of that co-occurring mental health concerns that may go along with the eating disorder, such as anxiety and depression. So we'll speak a bit more, or we'll spend a bit more time discussing the primary evidence-based treatments for children and adolescents. And really the gold standard is family-based treatment for eating disorders, or FBT. This is the treatment that we use most commonly in our outpatient clinic and within our partial hospitalization program for eating disorders at Children's Hospital Colorado. And then we'll translate how those interventions can be used for recommendations and best practices for providers and parents who may not actually work in an eating disorders clinic. So as we review these evidence-based treatments, please keep in mind that it's really important to have a multidisciplinary team treating the eating disorder because we know that eating disorders are one of the only mental health disorders with inherent medical complications. So the outpatient team or team in general may include a psychologist or therapist for really that primary behavioral treatment, a pediatrician for monitoring of vitals and medical stability, a psychiatrist for medication management if necessary, and then also a dietitian if needed. It's also crucial to consider how ambivalence about recovery may also impact treatment. And so by ambivalence, we really mean that push and pull that we often see within eating disorder treatment or often comes up within the context of substance use disorder treatment as well. So that knowledge of like, hey, these behaviors I'm engaging in may not be helpful for me in the long term, but I also feel like I'm not in a place where I want to stop that yet. So kind of having that push and pull. Part of the diagnostic criteria for anorexia specifically is having limited insight into the seriousness of their weight loss. So I just like to point this out because it's literally built into the diagnostic criteria. It's really important for the sake of having empathy for these individuals with eating disorders, that it's extremely normal and really expected that they often don't have insight into the severity of their illness. And this ambivalence is true for a lot of eating disorder diagnoses, not just anorexia. And if they do have some insight, again, there's still that push and pull about wanting to get better, because the eating disorder can serve a lot of purposes. So maybe it's serving as a method to change body weight or shape. Maybe it's serving a method to have control over some aspect of their life. Maybe it's serving a purpose to help regulate emotions, whatever it is for that individual. So, in other words, the eating disorder serves the individual and feels as if it is a part of their identity, or at least something that is serving a purpose. So, because of these reasons, limited insight into their illness and then sometimes limited motivation for recovery is expected. And those are very normal components that we consider within treatment. So, family-based treatment, or FBT, is the most evidence-based treatment for children and adolescents with eating disorders. It was originally designed as an outpatient treatment, is made to last 6 to 12 months in duration, and focuses on empowering caregivers to set limits on the eating disorder and help stabilize their child's nutrition. Treatment is split into three phases. Eating disorder treatment really loves phases, but phase one focuses on the caregivers setting those limits on the eating disorder behaviors. So this may look like caregivers serving larger portions and more variety than maybe their child's eating disorder wants, setting up structure around meal times, which we'll talk about in a little bit more detail, not following rules about the child's eating disorder, that maybe they have for like food preparation. For example, using only certain utensils, not using butter or oil, those sorts of things. So the patient and family, once they're ready to move on to phase two, after we've largely stabilized nutrition, weight is restored, the child or adolescent is generally compliant with the nutrition, we would then move into phase two of treatment, where we slowly return control back to the adolescent. And right, we know that caregivers often need to take more of that control in phase one, because of that limited insight and potentially that limited motivation for recovery. But the goal, of course, is always to get the child back to healthy, independent functioning. So with slowly returning that independence back to the child, that could look like helping, them guide them in portioning, starting to eat unsupervised with peers, that sort of thing. So kind of slowly guiding them back to being independently managing their nutrition. And then finally, phase three is when we want to see that maintenance of progress so they're able to maintain that nutrition structure themselves, maintain their weight, eating disorder thoughts and urges for those eating disorder behaviors have decreased. So, for example, eating disorder behaviors that we might see could be urges to restrict, could be purging, whatever it is for that specific child. So, in general, we see a decrease in those eating disorder thoughts and behaviors. And we're moving to addressing either co-occurring mental health concerns like anxiety or depression, or maybe doing some identity work to explore who they are outside of their eating disorder. In our eating disorders program, if you ask kiddos, how much of their brain space is taken up by thinking about eating or weight or shape, generally they'll say more than 90%. And so a good portion of phase three is focusing on, what do we fill the rest of their identity with if they're not devoting 90% of their time to thinking about the eating disorder topics. So in addition to understanding those three phases of FBT, it's also helpful context to know that there are five main tenets or like five philosophies of treatment that help guide it throughout. So the first tenet is that clinicians empower caregivers as the main agents of change. Again, that's because we literally need to save the child's life oftentimes because we know that eating disorders can be associated with such severe physical and psychological impairment and consequences. So we as clinicians empower caregivers to help set limits on the eating disorder. We also want to take an agnostic view regarding the cause of the eating disorder. So, in other words, we know that regardless of how the eating disorder started, the treatment for it is largely going to be the same. And just like any other mental health concern, or really any other, a lot of like physical health concerns, it's really hard to pinpoint the cause of an illness to just one factor. And we know eating disorders are influenced by, biological or genetic factors, psychological factors, and social factors. So because of that, we want to make sure that we're reserving our focus to be on how to stop the eating disorder now rather than maybe what caused it years ago. We also want to practice externalizing the illness from the child because we know that, right, kids cannot simply choose to stop their eating disorder behaviors. If we could tell a child to eat or tell a child to, stop doing XYZ, then they wouldn't need to be in treatment. So this can often help build empathy, especially for caregivers and providers. Say if we're referring to a kid's eating disorder as Ed, right? Like Ed is the one who's really upset and distressed at meals, not that kid at their core. Just as if, we wouldn't call if a kid had a cancerous tumor, we wouldn't say that the cancerous tumor and the child are one and the same. They're separate entities. So that can help build some empathy as well. The fourth is that the therapist takes on more of a consultant role. And that's because we know that the parents are the experts on their child and their family. We're simply a guide for the eating disorder, and we want to try to make treatment as sustainable as possible for each unique family. And then finally, we want to take a pragmatic approach to addressing symptoms. So, in other words, we really want to get at those behaviors and set limits around some of those eating disorder behaviors that we might see. And in other words, it's almost like, right, we have to stop the bleeding. So, we need to stop the restriction, we need to stop the purging, we need to establish regular eating habits. So again, really focusing on that nutrition stabilization and weight restoration, which then therefore paves the way down the road to address more of those eating disorder thoughts and cognitions that often come up within treatment as well. And it's also really important just to keep in mind too how eating disorders are on a spectrum. And it's actually very, very common for individuals to move from meeting diagnostic criteria for one eating disorder to meeting diagnostic criteria for another at a different point in time. Because of this, it can be helpful to think about applying these same recommendations, regardless if, say, your child has a fear of eating carbs, as maybe we'd see more commonly in anorexia. Or maybe they have a fear of eating foods with a certain texture, say crunchy foods, like we would more commonly see with an ARFID diagnosis. So regardless, right, we're setting limits on that eating disorders rules. So if a child was afraid of carbs, right, then we would do some exposures around carbohydrates and serve pasta. And if their feared stimulus was crunchy foods, we would do exposures and serve crunchy foods, right, to help build that distress tolerance for whatever the specific feared item is for that child. So as you can see, this is very similar to the treatment for anxiety-based disorders. So if you have social anxiety disorder and fear of public speaking, the treatment is repeated practice and exposure to public speaking. If you had a fear of or a phobia of dogs, right, the treatment is repeated in practice with interacting with dogs and exposures to them in general. So therefore, although FBT was originally designed to be used with those with anorexia, we can use more of this transdiagnostic lens to see how these recommendations could apply to other diagnoses or behaviors. I always joke too, I think I have one of the worst sales pitches in history of like, what do you mean? Like, to help my kid get better, we have to do this really unpleasant, feared thing over and over again. I think any exposure-based treatment can be really difficult, but really, really important. And then when we speak of kind of modifying for different diagnoses, for example, for FPT for bulimia, We might focus on setting limits around bathroom use to interrupt purging. So maybe, we say like, hey, we have to wait at least 30 minutes after eating before we use the bathroom. For FBT, for avoidant restrictive food intake disorder, ARFID, we might focus on reducing avoidance of certain foods based on textures, again, by doing those repeated exposures. And then randomized controlled trials, when thinking of outcomes for FBT, randomized controlled trials, so research, shows around a 75% treatment response rate for FBT with anorexia, which is defined as an improvement in weight and the eating related symptoms. And then results also show around a 40% full remission in adolescents at the time of discharge, with up to 50% full remission at 12-month follow-up, which is defined as a BMI that's at least 95% of their expected target weight, and then eating disorder thoughts and behaviors that fall within kind of the normal population range. And then there's also modest research support for FBT in the treatment of other eating disorder diagnoses, such as bulimia. So these numbers highlight that while FBT can be successful, it's also really, really important, again, to follow evidence-based recommendations to try to maximize treatment effectiveness. And then transitioning a little bit, so we've been talking about FBT. We'll spend a few minutes talking about some additional evidence-based treatment for eating disorders. So really the other kind of gold standard evidence-based treatment, if you will, for eating disorders is CBTE, or that enhanced cognitive behavioral therapy. This treatment is transdiagnostic in nature, meaning that it's designed for all the eating disorders across the spectrum. It was originally actually constructed as a treatment for adults and is projected to be about 20 to 40 weeks in duration. CBTE involves helping patients work through their ambivalence for change with the goal of helping the patients decide themselves to engage in treatment and engage in nutrition stabilization and weight restoration. So you can see how for folks that may have that limited insight or motivation, CBTE might be difficult to use at least at first. So just, comparing to FPT, there are pros and cons to this approach, just as with any treatment. But altogether, CBTE is really that gold standard treatment for eating disorders in adults. So although CBTE was originally designed for adults, there is evidence that it can be effective when used with adolescents as well. So really the primary difference between CBTE compared to family-based treatment for eating disorders is really that rate of weight gain is quicker within the use of FBT for treatment. And then we see a greater decrease in eating disorder behaviors using FBT compared to CBTE. However, these differences tend to decrease as time goes on, and both appear to have some promise. So although FBT can be helpful when we need to quickly reverse the weight loss and harm from the eating disorder, or maybe when there's, again, that limited drive for treatment or for change, FBT can be helpful. And then, as you can imagine, the other kind of main difference is that level of caregiver involvement. So FBT can be used when parents have the time and the capacity to engage in treatment. And again, if the child or adolescent has some motivation, then potentially CBTE could be a good fit as well. And then another evidence-based treatment I wanted to quickly mention is avoidant restrictive food intake disorder, or ARFID. And this is cognitive behavioral therapy for ARFID. This treatment consists of 20 to 30 sessions across 4 treatment stages. You might also combine CBT for ARFID with parent-supported nutrition, so kind of more of that FBT lens of helping to increase nutrition structure and set some limits on the eating disorder behaviors, and then also engaging in those exposures. So the goal of CBT for ARFID is really to address those nutritional deficiencies, expand the variety of foods consumed, and stabilize weight and nutrition. The goal isn't that everyone with ARFID goes through this treatment and then enjoys all the foods, but rather that a variety of foods is now tolerated and that they no longer meet criteria for ARFID. And then another treatment approach, I believe this is my last one that I'm going to spend just a few minutes because I think it can be really helpful, especially for caregivers. So another treatment approach I want to mention is emotion-focused family therapy. This treatment is used as more of an add-on to FBT for maybe patients who might be somewhat treatment resistant. So we know that some individuals might use the eating disorder as an attempt to control their emotions in some way or to regulate their emotions. So, for example, restricting food can often result in blunted emotions. Engaging in purging or self-induced vomiting can provide some relief. So, because of this, emotion-focused family therapy gives caregivers the tools to essentially model how to describe and process difficult emotions, which can be really helpful for the kiddo to see both from a modeling perspective of like, hey, this is how you label and deal with hard emotions, and just for helping the kid learn those tools for themselves to use in the future. So, in other words, the parent becomes almost like the emotion coach. And so the one of the main interventions that you'll find within emotion-focused family therapy is called emotion coaching. So you can definitely search this up and you could find the steps. And then I believe you'll have access to these slides as well. So there's 5 steps to emotion coaching. And essentially, I like to call it fancy validation of keeping in mind you're not agreeing with that tough emotion, or rather the reasons that they're feeling that tough emotion. However, you're trying to convey that you understand, even if you don't feel the same way, you can look at it through their eyes and understand why they might be feeling those tough emotions. So, for example, at a meal, you could notice that a kid is starting to fidget. And so you might say, like, hey, like, I see something's going on, you seem anxious. And then the fancy validation means you just add a couple becauses, like becauses of why you would understand they're feeling like that. So I can understand why you might feel anxious because it's scary to try new things, especially when you don't know how it'll go, and because dinner is always the hardest meal of the day, or whatever those reasons might be for your kid. And then step 4 and 5 is then following up with conveying emotional support, so helping to meet that need, or offering them a way to problem solve in the moment, or maybe skills to use if needed. And then I will end here with my last few slides on best tips and practices for caregivers and non-specialty providers. So really these takeaways from this presentation. So one of the most important steps to take involves recommending that caregivers implement greater mealtime structure. So we recommend that caregivers serve 3 meals and 2 to 3 snacks depending on your child's needs. And this would look like the caregiver choosing, preparing, and portioning the meals and snacks, again, to help set limits on some of those eating disorder rules. And then setting time limits on meals and snacks can also help set a limit on the eating disorder's attempts to avoid or delay nutrition. I'll often hear caregivers say, a 30-minute meal turned into a 2-hour meal. So, in other words, we would generally offer them the food first. If they refuse the food, you would have present them with supplements such as Boost or Ensure. And then if they're not able to complete that nutrition through the food or through that nutritional liquid supplement, then we might use a behavior plan system with rewards and consequences to help encourage motivation. So because we know that it's normal and expected, part of an eating disorder to have some ambivalence regarding treatment and gaining weight if needed, we might often rely on external incentives and consequences to help encourage some of that behavior change. So just as if, for example, your kiddo had trouble meeting homework deadlines, you might give them some incentives, additional incentives to turn in their homework on time. So same kind of concept. If a kiddo has difficulty with eating, maybe they might earn additional screen time after completing a meal or snack. So we want to communicate that refusing nutrition is not an option. So in other words, we need to satisfy that basic need before we can do those other fun things in life. So building in a set of incentives and consequences if needed. Incentives are always more fun if we can use those. That can be really helpful. And then a quick word too to engage schools. A 504 plan can be really helpful to request potentially a private place for your kiddo to eat with school staff and provide additional structure and supervision. Might be helpful to remove access or excuse attendance to gym class for a while, as well as other triggering classes, and have excused absences for medical and therapy appointments. So, wrapping up and consolidating this information, these are the few kind of bite-sized recommendations. So, first, we'd recommend that caregivers supervise meals and implement structure. We'd also recommend that caregivers provide emotional support by validating those really, really intense emotions and distress that their child's feeling using that emotion coaching framework, while still remaining really firm on setting limits for the eating disorder. And then finally, we'd recommend that you or the caregiver set up regular weight and medical checkups from their PCP or a physician if needed. So in bold there, we want to increase parental involvement in meal times, set clear limits and expectations while still being emotionally available and really validating those tough emotions, and then initiate treatment and medical monitoring as necessary. So since y'all will have copies of these slides, I just wanted to point out these last handful of slides will have online resources for caregivers and providers with support groups, education, research, training materials, as well as book resources for both providers and caregivers. So with that, I will stop sharing my presentation and turn it over to Dr. Martin-Wagar, and then I'm happy to answer any questions at the end. Thanks, everyone.
Thanks, Dr.
Thanks.
Horvath. That was such a lovely overview. Thank you. Just pulling up my slides. All right. Let's see if this, how are we looking? Can we see?
Looks great.
Perfect. Thank you. It's so good to meet with folks this late afternoon. My name's Caitlin Martin-Wagar. My primary role is as a faculty member in the Department of Psychology at the University of Montana, where I run a research lab called the Laboratory for Eating Disorders and Equity. And essentially, we study improvements to eating disorder treatments, mechanisms of change, and spend a lot of our focus on sociocultural factors within eating disorders. And a big part of our research area is weight stigma. So that's the main topic that I'll be talking about today. Um, I also direct our University of Montana Eating Disorder Training Clinic, which is a clinic where we see patients, but our patient load is relatively low because our intention with the clinic is to train generalist clinicians to be able to competently treat eating disorders. You know, the field has been over specialized for too long. So it leaves the vast majority of physical and mental health care providers without the tools that they need to be able to assess and treat these disorders. So I really want our fields to be able to start to see this more as a generalist issue, given what Dr. Horvath shared about the prevalence rates. This is, much more common than people realize. So that's what our clinic focuses on, and we deliver those exact same evidence-based treatments that she reviewed. I'm also a licensed psychologist in private practice. I see, a handful of folks weekly, just to make sure that I'm able to still train my students and stay up to date on things. So I'm going to talk about weight inclusive healthcare and the role of weight stigma and eating disorders. I also think if you're not in healthcare, this is going to be pretty relevant, and there's going to be some pieces that are really, helpful to hear about. So don't feel like if you're in another setting that this is, outside of the scope of like a useful a use of your time. I also want to mention that I am recovering from walking pneumonia, so I'm mostly doing better, but I might every once in a while I might have to cough a little. So my apologies. I'm not 100% quite yet. In terms of terminology, you're going to hear me use particular terms throughout this conversation, this talk, and the Q&A. And I'm going to be using terms, typically I'll use higher weight or larger body when I'm talking about higher weight people. Um, and the reason that I'm doing that is because we have some good research and lived experience where folks have shared that some of the terms that we use in medical settings, like obese, overweight, or even some of those euphemisms like big boned, can be really painful and stigmatizing terms and negatively impact folks. So, people with lived experience that have been included in research studies have identified that more neutral, descriptive terms are preferred. There's also a growing movement of people that are reclaiming terms like fat, kind of like we've seen with people reclaiming the term queer, for example. Or me, the first magazine I ever subscribed to when I was 18 was Bitch Magazine, like these reclaiming movements to be able to, better support viewing this again as the initial neutral term that it once was before it carried stigma. But the most important thing is, I think, asking people what their preferred term is. That's best practice. But when you're talking about a group of people, you obviously can't ask everyone. So that's why I'm using the most commonly endorsed preferred terms, which are larger body and higher weight. All right. And we are talking about stigma. And I think when we talk about a topic like that, it's important for us all to realize that this is a lifelong journey for us to unpack and unlearn some of the weight bias and fat phobia that we've learned throughout our lives, because these really are messages that we start learning really young in life. So I want folks to kind of consider their own thoughts and feelings regarding weight and body shape and body size, and interrogate that a little bit in a non-judgmental way, like without guilt or defensiveness, because we are all on a journey to be more weight inclusive in our approach. And some people might be at the very beginning of their journey, and some people might be further along. But for every single one of us, this is a lifelong journey to be able to interrogate the role of weight in our society and how we approach and support people of size. And know that, if you do, have your own weight stigma towards yourself or others, you are not alone at all in that. We do know that, there's really high rates of weight stigma, and even on the implicit attitude test, which some folks might have taken in this area or for things like race. If you go to the Harvard's implicit attitude test website, you can take this test yourself, and you can see here that the vast majority of people, well over half, have a preference for thin people compared to fat people. So it might be interesting to take yourself, and the link is in the slides in the notes section. And I know those will be sent out later. So for those that are newer to this topic, weight stigma essentially means like pretty unfavorable attitudes, stereotypes, and beliefs about people with higher body weight. So some of those stereotypes that are really prominent are things like believing they're unhealthy, believing that this means something about their personality. So a lot of times, our patients in clinic might say that they feel like they have no willpower, and they've received messaging just like that. We know that weight stigma is particularly prevalent in healthcare settings. So we know, I thought this was like a comic that really perfectly described what happens where this is a well-documented phenomena that's noted in the research, but also something that my patients share all the time, that they go to see their doctor and they have a health condition that truly has nothing to do with weight, and they're consistently told immediately the thing that they need to be doing is losing weight, as if losing weight would be the answer to all of their issues. And we know that this can result in some misdiagnoses and a lot of healthcare avoidance, given the poor treatment they're experiencing in these settings. Folks might also note when they go see their doctor, almost in every setting, the first thing, no matter why you're there, the first thing they ask you to do is hop on that scale. Which, if folks aren't familiar, you can politely refuse if they don't need it for any like dosaging of medication, for example. Um, if you feel like that's not a helpful thing for you. Weight stigma is also incredibly prevalent. We know from the research that the rates of weight-based discrimination are pretty similar to the rates of racial discrimination, so still very common. and in some studies was endorsed as the third most common form of discrimination. And there's, an intersectional impact where if people have other marginalized identities, like if they're a woman or they're a racial ethnic minority, that they have even higher rates of weight-based discrimination. And in youth, weight-based bullying is the number one way kids are bullied at this point. So really, really prominent. But unfortunately, in our society, we often think of it as almost acceptable and that it's funny. It's often like in sitcoms, higher weight people are often the butt of the joke. So kids learn this really early. This is a billboard campaign out of Georgia called Stop Sugarcoating It, Georgia. And it was a public health campaign that was intended to encourage families to get their kids enrolled in weight management. But you can see how stigmatizing some of these messages are. And I can imagine like kids in their family vehicles or in on the bus looking up and seeing these portrayals of kids that share similar body types and perpetuate some myths about weight can be so incredibly harmful. And because of this, it doesn't surprise me that research finds that kids as young as 3 exhibit anti-fat attitudes. So it starts incredibly early where they hear these messages. And because of all that, it also is not surprising to me at all that people often internalize these messages. So they experience what's called internalized weight stigma, where they essentially become their own worst enemy, where they tell themselves all of these really negative messages and feel like they deserve poor treatment and stigma and discrimination because of their body size. So really that self-blame and thinking that who they are as a person is lesser, that they're less worthy because of their body shape or weight. Besides weight stigma being quite common, unfortunately, there are a lot of adverse health outcomes, both physical and mental health outcomes related to weight stigma. So we know that things like disordered eating and eating disorders and body image issues are more common for those that have experienced weight stigma, and especially those that have internalized weight stigma. But it's also associated with all sorts of adverse mental health outcomes like depression, anxiety, substance use, suicidal ideation, and a lot of physical health outcomes. So I do a lot of trainings with, healthcare providers, physicians, nurses, other folks in the healthcare system. And folks are often coming in with really good intentions and the goals of supporting their patients of size. And I think what's really important is without having a weight inclusive approach, the patients are often not going to follow any recommendations. They're going to want to avoid healthcare. We know that it's actually associated with reduced exercise when people experience weight stigma. We know exercise is one of our most robust predictors of well-being and health. Um, so unfortunately, um, any of this like tough love or stigmatizing types of comments and approaches in healthcare really produces behaviors that are the opposite of healthy behaviors. Um, we also know that weight stigma is associated with an increase in all-cause mortality and all sorts of issues like cortisol reactivity. And we will talk a little bit about what we know about the relationship between health and weight in our time together too. Besides physical and mental health outcomes, we also know that there are other really meaningful health outcomes and social outcomes and academic outcomes. So, for example, a recent review found that adolescents had much worse social outcomes when they experienced weight stigma. So, fewer social supports and connections, more bullying and rejection, and worse academic performance and outcomes, including lower grades and engagement in the classroom. And I think it's really important when we're talking about weight stigma and adverse outcomes that we remind ourselves that these adverse outcomes are not because of weight, they're because of the stigma towards people with higher weight. A lot of these studies have controlled for other factors. So, for example, school districts that have a lot of body diversity and less weight stigma and bullying in the schools don't have these same negative outcomes. So, it really is the stigma piece that's driving the poor outcomes and not the weight status itself. So the good news is that means we can do something about it and we can shape our environments to be more weight inclusive. I will say that often when I talk about weight stigma, I know people are sitting there thinking, okay, but what about being higher weight? Isn't that unhealthy? Like, shouldn't we care about health? And I want to speak to that directly because the weight science is incredibly complicated, and we really don't know as much as we think we do when it comes to more weight, meaning more health problems. The literature just doesn't stack up that way. So let's talk a little bit about that piece. And I also encourage us to think of health as something holistic that includes physical and mental health. So one issue with the current weight science is that the link between health conditions and weight is really hard. It's really hard to do that research because there are so many factors in a human's experience that are hard to control for. So really right now, this literature base is pretty complex and poorly understood. We also know that weight loss is not maintained long term by most. Most studies and meta-analyses find that 95% of people gain the weight back and end up even at higher weight than what they started, while really disrupting their relationship with food, eating, and their bodies. So we don't see that this is actually a very effective approach to even encourage. We have very little long-term data about weight loss, and what we have doesn't look great. And often these studies focus so much on whether or not the study produced weight loss and less focus on whether or not weight loss is able to be tied directly to health changes. Because ultimately, if we care about health, then we can target health directly, and really, whether if somebody's weight doesn't change but their health improves, that should be the piece that we really care about. And finally, confounding variables, even weight stigma itself, are almost never examined in these studies. And with the weight science literature, there's actually a term that's been coined because so often studies find they go into these studies, they're expecting to find the higher weight people have more health problems, have more mortality. And it's so commonly found that there's lower mortality rates among folks in the overweight and obese BMI categories. Obviously, BMI is, not meant to be an individual measurement, and it's not a great measurement. But even with that, we find this finding that there's lower mortality rates among these folks. And instead of just kind of, noting that finding, they've come up with this term of obesity paradox because it's a paradoxical finding. So just as like a couple examples, especially as people age, like older men and older women with a BMI in the overweight range, there's no association with increased mortality, and it's really only the really top, people highest weight that there's a modest increase in the literature. And a lot of times it depends on the health condition. So, as an example, research finds that people with higher weight are more likely to survive a stay in the ICU than those of lower weight. And I want to highlight this with a particular example too. Um, this is a research study that examined the relationship between weight status and likelihood of dying from the flu. And the researchers first found, indeed, that higher weight people were more likely to die from the flu. And if they had just left it at that, then we would, continue to have this idea of higher weight, more health problems. But luckily, these researchers were mindful of confounding variables and they controlled for several variables. When they controlled for when participants received antivirals, they found that the relationship between weight status and dying from the flu was no longer significant. So, really, what was explaining it is when these people were receiving antivirals. I'm not exactly sure why, some folks, especially the higher weight folks, are delayed in receiving those antivirals. But my hypothesis is that, there's the healthcare avoidance component and delays, and then potentially some stigma from providers in delaying care because there's too much of an emphasis on body size versus what they're coming in for support on. So I think this is just a really good example of why it's so important that when we're trying to understand the link between health and weight, that we're really looking to the literature and analyzing any potential confounding variables that help us explain these relationships. So, um, weight stigma, very prevalent, has adverse outcomes, and health and weight are complicated relationships. Those are the main things we've covered so far. And I want to shift us to a little bit of what we can do about this, right? I think we can all agree that there's serious issues here, and we want to support people's full humanity in whatever settings they're in. This is a really important factor for anybody that works with eating disorders, but really, important for people in any setting. So I want to think about like in certain settings where you might see weight stigma show up, and then we talk through a couple ideas of ways you can have more size inclusivity. So, in eating disorder settings or in generalist settings where somebody's just kind of coming in to talk through some of their health challenges, it's really easy to miss an eating disorder diagnosis if we're using size as a relevant factor here. So, it's pretty common for people with higher weight to not receive a diagnosis. We know that only 6% of people with eating disorders are underweight by BMI, but it's definitely not the stereotype we tend to have in our minds. And we tend to also assume that higher weight people must overeat or binge eat when that might not be the case. So we need to be thinking about assessing properly for everybody across size. So that's one of the big ones that I always get worried about. We can't look at someone and know if they had an eating disorder. Um, the case conceptualizations and recommendations that people might make can be impacted, weighing people without consent or thoughtful rationale, like why do we want to weigh somebody and what will that do for them and what does it mean? Do we need to do that? Like if you're in a healthcare setting that they do weigh people, I like there's these little cards you can order that are at the front desk that you patients can hand to the provider and say, I'd not like to be weighed today, and it makes it a little easier on them. So I encourage folks to think about that. We also know in treatment settings that there's different weight gain recommendations and meal plans that disadvantage higher weight patients and don't allow them to reach full recovery because of stigma. We know from therapists that they think higher weight patients are less likely to make changes. They don't believe in their patients as much. So those sorts of things are concerning. Obviously, judgments towards higher weight colleagues and patients. In some settings that I've worked in the past, I've heard some of the most abhorrent comments made towards higher weight people in healthcare settings in particular. So I think just, all the ways that this shows up just in the workplace setting too. Um, Watching out for comments about good or bad body sizes or good or bad foods, healthy or unhealthy foods, like seeing all foods as having their place, and that really encouraging variety is important. Um, Definitely an emphasis of the role of weight in presenting concerns. I've also seen settings, including ones that I've been at before, where there's not been enough appropriate seatings or measurement tools, like, for example, blood pressure cuffs. Um, so those sorts of things, like, is the setting supportive of all sizes? I also think schools need to be really mindful about encouraging kids to track calories. In my private practice, I don't see all eating disorder patients. I also, see folks for other presenting concerns. And it's not uncommon for a kid to go through health class who never had any eating disorder or body image concerns and then become very obsessive. We know tracking calories tends to really externalize the eating process, and it tends to make people much more concerned. And we don't recommend that people use calorie trackers. Um, promotional materials, websites, like is there, very thin, especially white people as your photos that are the picture of health, like how are you displaying, what represents health and well-being? And then recommending weight loss without fully assessing whether there might be better approaches. So these are just some ways this might show up, and I encourage folks to kind of look and see where this might show up in their settings. So some size inclusive practices would be really useful for folks to keep in mind. So for example, a weight centric approach would be, somebody says they have knee pain and you recommend weight loss to them. We actually know that, from physical therapy, that hip strength is a major factor in knee pain, regardless of weight. So a weight inclusive approach would be to target that directly. So go to PT and address knee pain. Um, if a weight centric approach, if somebody felt body image issues, um, and they pursued weight loss, that would be a weight centric approach. A weight inclusive approach would be to focus on reducing body image concerns and reducing internalized weight stigma. A weight centric approach would be supporting people in exercising for weight loss or calorie burning. And a weight inclusive approach would be supporting people in exercising in a joyful way where they're well nourished and fed and it's compatible with their goals and values. Other things that folks might want to think about is shifting away from um, appearance to function, think about what our bodies are meant for, all the lovely things that our bodies do for us, allow us to hug a loved one, there's so many meaningful things. So kind of have that focus. Um, if folks are judging themselves or comparing themselves to others, like moving away from that objectifying approach and move more towards curiosity in terms of, um, I wonder what that person's, favorite hobby is, or I wonder like what makes them laugh, kind of getting more towards someone's real humanity versus their, external shell. Supporting people and curating their social media, that's a tough one right now, especially with the adolescents, but I bet a lot of us here also have our own stuff with this. So knowing that like algorithms are the more time you spend on something, the more you're going to get those messages. So having them kind of understand that piece and curate a size inclusive approach to be able to receive more useful messaging. I think it's also useful to explicitly teach people about weight stigma. Often people just don't know and how that's shaping their life. Once you see it, it's hard to unsee it. Um, I think identifying their values, if you're using CBT approaches, which I do typically recommend, just like Dr. Horvath with adults, that really is our gold standard. And there are, situations where patients might share things that aren't, really are true experiences that they've had. So, in any level of CBT, either for eating disorders or elsewhere, not to invalidate the valid, like maybe they are concerned they'll be discriminated against because they have received discrimination. So, like, that would not be like um, like a reframing moment. It would be more of a, validating and figure out how to support them given that reality. Encouraging regular eating patterns, reducing shame and having no good, bad foods, um, and encouraging people to reduce weighing themselves. Just for time, I'm going to skip this one, but you all will have these slides. These are just some, predictors of positive health outcomes that you could use that are not related to weight loss. Other things that folks can do is just be on that lifelong journey to better understand the role of weight stigma in your own life and the life of others. So kind of really interrogating your own views and perspectives, educating yourself on these things, really focusing on well-being versus weight, reducing how much you're talking about these things. Like I've received feedback from some of my newer friends that I've made since I've moved to Montana, about 4.5 years ago, where folks have told me like, oh my gosh, like you're the only person I know that doesn't ever talk about like, oh, I'm on this diet or make these negative comments about bodies. And they've shared that it's really liberating in a really different way. So you could really shape your, your environment and do that for others too. So not even complimentary ways of commenting on people's bodies, because ultimately you're reinforcing that there's acceptable ways of being and instead kind of noting what you like, oh my gosh, like you look so happy, or, something like that. That's more about their experiences versus their bodies. Um, using respectful language, thinking about the role of intersectionality and how this plays out for people, and how they might experience stigma in multiple ways, in compounding ways. Um, just kind of calling things out. Like I often do it very gently and with humor when I can. Like, if I'm at a work meeting and someone says, "Oh, I can't have that," like that's not I can't have that donut, like that's bad. I might be like, oh, donut's a joyous food. Like just a little like fun correction. And it really does shape your environment when you do this. Like there's been really cool changes that I've noticed from that. Also adopting weight inclusive approaches like health at every size is a really great resource for folks. And I have a list of resources at the end here that folks can follow up on. And really thinking of people holistically and not basing eating disorder potential diagnoses on low weight only. So those are some additional ways. And my final way is like a little bit more of like your context, your institutional stigma. Like wherever your setting is, the more you can have sturdy, armless chairs, that is a game changer for people. So for example, one of the classrooms that most of our classes are taught in for the graduate students at our university had these like tiny wooden chairs where you couldn't even fit like your thighs under the table, and it was so distracting to people. So I spent I think like 5 or 6 semesters submitting a request for like new seating, and I was like putting out research articles and why I thought they should do that so that the students could focus on their education instead of the distraction of their bodies. And I did have to push at it a lot, and they did finally about a year ago swap over and change out all the seating. So kind of just seeing like where are spaces that you can make the encouragement, consent-based weighing practices if weighing's part of your setting, really having your promo materials or like your websites have a wide range of body sizes and shapes, employing people with a wide body sizes and shapes, really advocating care for individuals with food insecurity and low socioeconomic statuses. They're experiencing a lot of weight stigma, and it's really important to be, thinking about ways to support them in accessing a wide variety of food. Um, if you're in a setting where this is relevant, challenging insurance or healthcare weight bias, sometimes insurance companies want to turn down eating disorder care for higher weight patients. And really just seeing eating disorders as present anywhere. These are generalists. These are things that we all need to keep an eye on. Like we've all been, whether we know it or not, we've been around folks with eating disorders, and see if there's any like assumptions or things that you might need to correct in some of your spaces, and trying to have like a no diet talk environment. So these are just some ideas that you can try in your settings to kind of shape things as well. And my final slide is just some books and communities that are useful. So I won't talk through these. You can look at these later. But I thought folks might want, have some continuing work in this area. So thanks so much.
Wonderful. Thank you so much, Dr. Martin-Wagar. Thank you also to Dr. Horvath for your great presentations, the wonderful information you provided. My name is Anna Kiley. I'm with the Montana Public Health Training Center, and we co-hosted this learning series this month in recognition of National Eating Disorders Awareness Month. With Kat LeMay's Center. So I am going to help monitor some questions now. We'll direct questions to both of our experts. We'll be pretty informal about it, so anyone can come off mute, and whichever speaker feels most compelled to answer that question, you ladies can just hop in. I will get us started with one that came in with registration. So for either or both of you, how do we get entire family buy-in for treatment of eating disorders?
I can hop in with that one, but feel free to add on as well, Dr. Martin-Wagar. But um, it is tough. I think, interestingly, part of the treatment for family-based treatment for eating disorders is so-called calibrating the family's anxiety for treatment. So if a family is not necessarily anxious enough, given what we know about some of the consequences of eating disorders, um, then that's our job is to kind of talk about some of those long-term impacts. And then on the flip side, if a family is already feeling very anxious, calibrating that down so it doesn't necessarily get in the way of treatment. So in general, I think approaching the family from a lens of empathy and a strengths-based approach of how can we make treatment fit that unique family, while still discussing those really important inherent consequences that we see from eating disorders. Even if it's really difficult and scary to talk about, I think that's really important. Something I actually wanted to add on is I most commonly see difficulty with buy-in with treatment from families when we think of something like atypical anorexia, which is when we see folks lose weight, and we call that have weight suppression and still have that fear of gaining weight and putting a lot of emphasis on how important body weight and shape is for how they see themselves. But to Dr. Martin-Wagar's presentation, there's definitely a stigma of, right, maybe folks who don't necessarily meet that underweight criteria, but have lost weight from a higher weight, are viewed as maybe not as serious or not needing care as immediately. So I think having those tough conversations with families and approaching from a lens of empathy is important. And then also exploring their own beliefs around food and weight, I think comes in handy too.
Yeah. Yeah. I think those are all beautiful things and really important. And um, it's such a tough situation because there's just so many myths around eating disorders, and a lot of times families just don't know. So that whole calibration is so key because explaining that this is life-threatening, right? Like this is like, not to totally scare people, but it's like a cancer diagnosis. Your child can die. And we do use those words, what coupled with the idea that, wow, and we have incredibly effective treatments. And that's the great news. There's so much hope. You've done all these things. You've made this call. You're doing all the right things and really like encouraging and building up the steps they've taken. So like coupling that seriousness with, but no worries, like we've got you. You're going to be all set in this, I think is really powerful. Something that, for those of you Montanans on here, something I've noticed that's been different from my previous states is there's such a high value for autonomy in this state. Um, and it's something we run in. I actually wonder, I wonder if like that's unique to any of these. I'm thinking like New Hampshire might have some of these values too, but this idea of really valuing people's autonomy, and people value their kids' autonomy a lot too. And once the treatment started, I find that we sometimes have some struggle with parents taking full control because they don't want to take the autonomy away from their kids. And it's just such a strong like cultural and family value that we have to often name and say like we love that. That's a great value. And right now your child actually doesn't have autonomy. It's the eating disorder that has autonomy. And I know like, Dr. Horvath referenced like the ed or the eating disorder voice, and like really separating the child from the eating disorder can be such a powerful part of that process if they understand like this is temporary and it's because the eating disorder is going to decide if we don't do this. So not ideal, but it's what we have to do in the short term.
Thank you both. Any questions from the audience? You're welcome to come off mute, raise your hand, or type your question in the chat. Okay, question here. Could be a silly question. Can someone be diagnosed with anorexia and ARFID?
I love that question. And technically with the DSM, no, but does it happen? 100%. We see this in clinical practice where people do truly meet both, um, but we can't do it in terms of the DSM. So what I'm curious to hear what Dr. Horvath's team does, but I know our team, we basically, diagnose with the most representative one. And then we do like somewhat of a hybrid model where we're incorporating components that are relevant to both of those sorts of presentations and behaviors. And it's tricky and it's like very person by person, but we actually know that if we, for example, diagnose anorexia nervosa and ignore the features of ARFID, that those folks don't do well in treatment because they're not feeling like that part's being addressed appropriately. So I find it really helpful to, know that they happen, and we can't do it in an official diagnosis, but we can at least tweak the treatment to make it more individualized to support any of the presenting concern or maintenance factors.
Yeah, I would agree with all the above. And I actually think that's such a great question. And again, one that comes up clinically so often. I think again, diagnosing with more often if they are showing features of both anorexia, typically from the DSM lens trumps ARFID. And with that in mind, you would definitely want to address features of both. I think as much as you can conceptualize eating disorders on a spectrum, I feel very strongly about that. We're addressing those core symptoms and fears that that child's or person's eating disorder has. And so again, kind of addressing all those core symptoms, regardless of whatever specific diagnostic lens it falls under. And then the other thing I'll add is again, not uncommon. We see all the time people who have met for ARFID in the past, and then maybe ARFID feels resolved and go on later to develop anorexia or vice versa, or like in close proximity, kind of waffle between the two. So not uncommon, but very important to address both.
Yeah, I think that brings up the whole issue in our field in general, where the diagnostics just don't line up with lived experience. Like in our settings, it's amazing how people are not fitting into these diagnostic categories perfectly. I do group supervision with some of our PhD students, and every time they do a new intake with a patient, I always, have them do a case conceptualization, and then I say, "What are you thinking diagnostically?" And I would say at least 80% of the time, the person's presentation does not neatly fit into one of the diagnoses. So it's been just it's been a learning experience for them to understand that our criteria is not kept up with the research literature. Like we know, for example, atypical anorexia is just as impairing both physically and psychologically as anorexia nervosa, but we're treating it differently. We're even giving it a name called atypical anorexia. The research is so clear on this, but the criteria in the DSM are not quite up to date. So I think folks just kind of know that it's a little bit of a weakness in our field, the diagnostics. So that transdiagnostic approach can be really helpful.
I'm going to address another question that was sent in with the registration. Or what is the distinction rather between an eating disorder symptom versus, say, depression and anxiety? How do you differentiate between those?
That is another excellent question and one that really depends on the person. So the way I like to conceptualize it is, um, are those eating disturbances, and most commonly, say with depression, we might see changes in appetite. So maybe someone's noticing less of an appetite. Is that just happening in the context of depressive symptoms, or is it happening outside of those depressive episodes? And similar to anxiety, it's super common to feel like nauseous or to have like GI upset, right? When you're feeling anxious. Are those symptoms primarily just occurring when the kid is in that anxiety producing situation, or is it occurring outside of it as well? And then, of course, looking at the level of impairment associated with those eating symptoms. So, again, like, is it resulting in significant weight loss, difficulty doing things socially surrounding food? So again, kind of looking at the duration and the context that those symptoms are happening in, and then how much impairment they're causing.
Okay, another question just came in the chat. Do you have some advice for being in a school-based situation in which me and my team would be the ones sitting with them during their lunches and encouraging eating during group therapy or group therapeutic interventions during this time.
Yeah, we love when this could happen. This can be really, really powerful, because in situations where somebody really needs to be weight restored and they have like an entire, 8 hours of their day where they're not supervised for eating, that's a huge missed opportunity. And we really want to get that weight gain to happen very quickly. We used to say like 4 pounds in 4 weeks was the goal, and now we know even more pounds in each week is actually even better. That is our number one best predictor of good outcomes, and we don't want somebody to be malnourished and underfed a day longer than they need to. So when this can happen, this is amazing. I think a lot of the things that were on Dr. Horvath's slides about like the parent piece of like, keep going, you got this, like the validating, I know this is so hard. I think you can use those exact strategies. Like, I think those are perfect for these situations. Um, I would also ask them what they find most helpful to be able to navigate and get through a meal. So for some kids, distraction is key. They want to look at things, read stuff, watch stuff, talk to somebody, not think about what they're eating, especially people that have more restrictive type eating disorders. Some people, they find it helpful to focus. So I think just kind of asking, like, what do you need from me? What would be helpful? Do you want to have a conversation through this? And encouraging, like, you got this, let's do another bite. And like some of those encouraging statements can be really helpful.
And then I would also add too, I think especially as school staff or something that I hear quite often is like feeling a lot of intense pressure to make sure the kiddo like gets through the whole meal and consumes it all. I just want to emphasize like that is not necessarily your role. It's just to be there for the kid and to supervise and to provide support, and that in and of itself is so meaningful. I would definitely agree with the recommendation to do some of that emotion coaching or validating and asking the kid what best supports them. The third piece I'll add on there is really if you can just shoot the caregiver an email and just say like, hey, like, I don't know, Alex completed half of their sandwich today and, their bag of chips. Then the parent knows, hey, at home tonight, I'm going to supplement for that half a sandwich that was missed. So really just to be there with them, provide some guidance and supervision is more than enough. And we're just thrilled when we can get school support in any way. So I really appreciate that question.
Other questions from those on the call?
I actually am someone who's in recovery from ED, and I went to a treatment center. And one thing I saw is they would do a lot of group games, like not like a verbal game, or like a game on a phone where they'd be like, get like guess something that is closest to this or whatever, and that helped provide enough distraction that people were like thinking about something else a little bit, but they could still also focus on their meals, and that seemed to be helpful. And the other thing I wanted to note is that sometimes with that weight restoration, that people struggle with the changes in their new bodies, and to just be aware of that, that it's a struggle as they see that happen. And not to say that they shouldn't weight restore, because they should, but just that they struggle with that and they feel heavy and bloated and feel weird about their clothing, and that those are things that need to be discussed with them.
Gosh, that's great advice. And congratulations on your recovery. That's amazing to hear. So happy. I would also mention too that with that piece around that excellent advice of, like being really mindful of body changes, that in that process, validating that experience, but also not reassuring, like, no, but you still look good, or, like, oh, you're not too big, like those sorts of comments, because inevitably our bodies change throughout our lives, and we don't want somebody to remember that certain body sizes were acceptable to others, and then later they change, their body changes, and they feel like, and they know, people share all the time with us, our patients share that people treat them entirely different as their body has changed through their life. So I find that even though it might be good intentioned, to be able to say like, don't worry, you're still so small, or like, you look beautiful, instead focusing on, other aspects of who they are and just tolerating the experience without accidentally reinforcing any stigma.
Could not have said it better myself. Thank you for those wonderful suggestions.
Another registration question. And this may have been directed at our first session, but I think that both of you will be really great to answer this as well. And there might be folks joining today that weren't able to join us a couple weeks ago. The question is, when do you get inpatient medical help for someone with anorexia?
Again, really patient dependent, but you want to essentially assess vitals and look for medical stability. So we're looking at degree of weight loss often. And again, with that caveat of it doesn't necessarily mean they're underweight. A lot of times we see, I think Dr. Martin-Wagar mentioned this too, but the amount of like physical impairment and stress on the heart that can happen from losing weight from a higher weight and then, becoming medically unstable in that way, I think is important to keep in mind. So we're looking at things like degree of weight loss, heart rate, blood pressure, those sorts of aspects. And then another big one to consider is have we tried outpatient treatment before? And how did that go? So do we need that additional support? So it's really that inpatient admission is when we're really concerned about medical stability.
Yeah, there's some nice guidelines too, and I'll see if I can find them and put them in the chat. But um, the main recommendation too is if somebody can safely be at a lower level of care, that they should be at the lowest level of care that's safe for them. So ideally, we want to catch these early so that people don't need inpatient, especially in some areas. Like we don't have inpatient, for example, in Montana, so we have to send people out of state, which is really disruptive, and there's not a lot of ability for that. So really just trying to find a way that they can be getting treatment while integrated in their life and dealing with those challenges. And of course, some people are going to need higher levels of care, but anytime you can, like the safest, lowest level of care possible.
Well, I'll mention as we have a couple more minutes for last questions that my colleague Kayla has put our evaluation in the chat. So standard questions that we ask from our training. So if you've have a moment to complete that evaluation as you hop off today, we would really appreciate the feedback. And thanks, Dr. Martin-Wagar, for putting that resource in the chat. Any last questions that folks have for our presenters today? Okay, well, we will ensure that the slide decks are made available, and I'm sure that they will continue to take questions following. We can certainly reach out to them with questions that folks have and connect for additional opportunities to collaborate, to chat. And thank you all so much for joining us. Thanks again, Dr. Horvath. Thank you, Dr. Martin-Wagar, and we will see you all next time.
Thank
Thanks
you.
all.